It's Saturday, September 4th, 2010, and registered nurse Kim Hiatt has just arrived to work for her morning shift at Seattle Children's Hospital in Washington. Kim has worked at Seattle Children's for 25 years and has spent the last 6 years working on the intensive care unit. Upon arriving to work that morning, Kim was pleased to learn that she would be taking care of an infant that she knew well, a baby that was born at Seattle Children's 8 months earlier and had been diagnosed with a congenital heart defect, one that would eventually require heart transplant. Kim was very familiar with the patient and the parents of the child, having cared for the baby several times over its extended stay in the hospital. A few minutes after 7 a.m., Kim received handoff report from the patient's night shift nurse and learned that the baby's ionized calcium levels had been steadily declining over the past few hours. As an experienced nurse, Kim knew that calcium levels played an important role in cardiac function, and she made a note to ask the patient's doctor for an order that would allow her to check the baby's ionized calcium levels more frequently throughout her shift. Around 9 a.m., the ICU team rounded on the patient. Kim reported that the baby's most recent ionized calcium level was 1.16, which was slightly below the desired lower limit of 1.2. Because of this, Kim suggested they give the baby some additional calcium to correct this imbalance. Kim proposed a dose of 10 milligrams per kilogram. The physician agreed that the baby needed some additional calcium, but was unsure about the amount to give, and told Kim that they believed the correct dose would be 20 milligrams per kilogram in this situation. After a short discussion, the provider reviewed the dosing recommendations in the electronic medical record and confirmed that the correct dose would be 20 milligrams per kilogram. Kim then left the bedside briefly to retrieve 2 vials of calcium chloride solution from the medicine supply cabinet located in the hallway. When Kim returned, the physician was still in the room, using the bedside computer, and informed her that they had just entered the order for calcium chloride. The physician again verbally confirmed the intended dose as 20 milligrams of medicine per kilogram of the patient's weight. Kim knew that the baby weighed 7 kilograms, so she calculated the medicine dose in her head and concluded that the baby would need 140 milligrams of calcium chloride. Kim ran her mental math by the physician, and they agreed that 140 milligrams was indeed the correct dose based on the patient's weight. Under different circumstances, Kim probably would have used the electronic medical record to double-check her calculations and record the medication dose on the patient's electronic chart before she gave it. But because the physician was currently using the mobile bedside computer, Kim decided to proceed with giving the dose without checking the order first, and settled on recording the information on a hard copy of the patient's bedside flow sheet. After documenting the dose on the flow sheet, Kim carefully drew up 14 milliliters of the medicine into a syringe and programmed the bedside IV pump to run the medication in through a central line over the next 30 minutes. As the medicine was infusing, Kim also noted that the baby needed a diaper change, and while she was doing this, a pharmacy tech entered the room and asked Kim to sign off on a delivery of narcotic medications that had just been delivered to the unit. Another staff member from clinical equipment arrived moments later with an IV pump that Kim needed to hang some additional medicine for the patient. And a third staff member entered the room to discuss the patient's nutrition plan with Kim. As Kim was helping these staff members to work through their various needs, the patient's parents also arrived. Kim quickly finished up her task and exited the room to give the parents time to visit with the baby. It's now 3 hours later, at approximately 12:10 p.m. Kim recognized the baby had developed an irregular heart rhythm and reported it to one of the cardiologists on the unit. The baby's heart rate had been bouncing between 190 and 140 beats per minute. But after a quick review, the cardiologist concluded that because the blood pressure was normal, there was likely no immediate cause for alarm. Still concerned, Kim stayed at the patient's bedside, monitoring them closely for a short time. After approximately 20 minutes, Kim noted that the patient's heart rate had begun to settle, and there were no other signs of distress. A few minutes later, she gave a quick handoff report to a fellow nurse on the unit and then left the floor for her lunch break. Within 15 minutes, Kim was summoned back to the patient's room. When she arrived, she noticed there was a flurry of activity. During her short break, the baby's condition had begun to deteriorate. The blood pressure had dropped significantly, and their heart rate was becoming erratic. 3 nurses and 2 physicians were working to get the baby's rhythms back under control. Kim immediately began to assist the others in helping to stabilize the patient. While doing so, Another nurse in the room commented that there were 2 vials of calcium chloride located on the supply cart at the patient's bedside. In that moment, something clicked inside Kim's mind. She recalled the dose of calcium chloride that she had given earlier and immediately realized that she had made a critical error. A miscalculation had led Kim to give the baby an overdose of medication that was 10 times more concentrated than she had initially thought. Kim immediately reported the error to the attending physician. She entered a note in the patient's chart and reached out to the baby's parents to alert them that she had made a mistake. A short time later, the unit charge nurse entered and asked Kim to leave the patient's room. In the hallway, Kim was confronted about the error by the director of the ICU, and she was informed that she was being placed on administrative leave, effective immediately. In the days following the event, the patient developed a severe brain bleed, likely related to the use of heparin, which was required to prevent the patient's blood from clotting while being maintained on life support. Unfortunately, the baby's condition did not improve. 4 days later, the baby's parents were left with very few options and ultimately decided to withdraw care, ending life support. In the moments after the baby's condition had begun to deteriorate, Kim recognized her error. She realized that she had mistakenly calculated the volume of calcium to be given, believing that the concentration of medication was 10 milligrams per milliliter, when in fact the concentration was 100 milligrams per milliliter. The dose she had given was exactly 10 times more powerful than what she had intended. This is likely because Kim was focused on giving the medication quickly, and she hadn't stopped to verify the order or the dose calculation in the electronic medical record. We know humans are fallible, and it's understandable that Kim could have easily confused the medication concentration in her mind. The fact that she had just finished a conversation with the provider moments before about whether the correct dose should be 10 or 20 milligrams certainly didn't help. With so many different numbers, concentrations, and calculations floating around her mind, it's easy to understand how a decimal point could shift and cause Kim to make this simple but critical error. The hospital had a policy which was intended to prevent such errors. The policy stated that a nurse should always verify the orders in the electronic medical record prior to giving doses of medicine in non-urgent situations. This would have been difficult for Kim to do because the doctor was currently using the bedside computer that she would have needed to verify the order. At that moment, likely because the provider verbalized the order to Kim directly, she felt confident in the information and in her own ability to calculate the dose correctly and give the medicine before verifying the order. It is not known if the physician in the room was aware that Kim would have needed to use the computer briefly to comply with the policy, or if they were just simply busy and the thought didn't occur to them. Perhaps this provider was unaware of the practice of cross-checking. Cross-checking is a process used in highly reliable organizations in which all people present, regardless of role or job function, are encouraged to pay close attention to the environment around them, to be aware of other people's activities and feel empowered to speak up when they notice or suspect that something has deviated from the intended path. Regardless, if the cause was either lack of understanding or oversight, Kim did not ask the provider for a chance to verify the information, and the provider did not speak up and offer Kim an opportunity to look over the order. To a degree, this helps us to understand at least part of the reason for why this error was not caught prior to giving the medication. But there was also another opportunity to catch this error after the dose had been given. If Kim had taken a brief moment to review her work, she may have spotted the error in her calculation, allowing her to stop the infusion and prevent harm to the patient. Unfortunately, likely due to the competing demands of patient care, Kim's attention was diverted away from the task at hand in those precious few seconds after the IV pump had been programmed, and Kim likely did not pause momentarily to review her work. In healthcare, this type of self-review is often referred to as STAR. The acronym stands for Stop. Take a moment to focus your attention on the task at hand. Think about the activity you intend to do and plan your actions accordingly. Act. Complete the action or task as you plan to carry it out. And review. After completing the task, take a moment to reflect on the activity. What opportunities exist for this process to deviate from what was intended? Check to ensure you followed established safety protocols. And consider how you can double-check or verify that the activity has been done as safely as possible. Although there were a few simple things that Kim could have done to help protect herself and the patient from this type of error, the failure does not rest on the shoulders of the nurse alone. There is no doubt that due to the multiple disruptions Kim experienced from other staff members shortly after giving the medication, it probably would have been difficult for her to stop and review her work in real time. This points to a broader failure in the system, a failure of the hospital to establish and inspire a culture of safety. A culture where nurses and other teammates understand that the most important tasks are never to be interrupted. Nurses should feel that they have the authority to ask for non-urgent tasks or conversations to be postponed until after they have had a chance to finish the critical processes at hand, such as medication administration and documentation. In healthcare, this practice is often known as a zero interruption zone. It is imperative that nurses and other staff members are aware of zero interruption activities and do their best not to interfere for non-urgent matters. Healthcare is a complex system, and it is difficult to prevent all patient harm. In the best-case scenarios, when problems like these come to light, they should be investigated by hospitals. Those involved should be treated with respect, and all parties should work together to find meaningful solutions to the problems. Unfortunately, as this case also illustrates, that does not always happen. On September 28, 2010, 24 days after the event, Kim Hiatt was released from her job at Seattle Children's Hospital. The facility cited the fact that Kim failed to follow their established policies of reviewing the patient's chart prior to giving medications as the primary reason for her dismissal. Kim also received a reprimand from the Washington State Board of Nursing, which would have made it exceedingly difficult, if not nearly impossible, for her to find another job as a nurse. Kim was devastated by the error she had made and certainly grieved the loss of not only her patient, but also the loss of her job, a part of her identity, and her passion as a caregiver. Ultimately, in April 2011, struggling to cope with the stress and the torment the error had caused for her, Kim Hiatt took her own life. This tragedy serves as a reminder of the faith that our patients place in our ability to care for them during their most vulnerable moments. Healthcare has long understood this responsibility to our patients through the Hippocratic Oath. First, do no harm. Unfortunately, we have yet to make good on this promise to our patients, and we have certainly not yet learned the same lesson with respect to our colleagues. Too often, healthcare organizations fail to realize that the harm caused doesn't always stop with our patients, but also extends to the caregiver as well. To help join the fight against these types of medical errors, please share this video with someone you know. If you'd like to learn more about patient safety and ways that you could help, visit ihi.org.